The first 30 days after discharge from an ACS event are the most vital for the patient. It's a time of high stress, it's a time of high readmission, and to minimise the stress and the readmission, the discharge education process becomes very important. Our data shows that nearly 70% of patients do not come back to cardiac rehab programs. So for that group of patients, this might be the only time we have to impart important education and information for good outcomes after their event. So what we wanted to do was explore what happens in this 30 days. We did a systematic review as well, and we found that there was very little evidence for discharge education, so we found a gap in research as well. And although that's good news for researchers, it's not good news for practice. So we just wanted to explore what was going on in those 30 days. So it was an observational trial, but more importantly, the technology part of it, we wanted objective data. We weren't that keen to get self-reported data from the patients. So that's why we used the GPS and the activity tracking, and we called it the Keeping on Track study, because not only were patients being monitored or tracked, they were also keeping on track for their discharge education advice, which includes seeing your doctor, going to your cardiologist, keeping your meds up to date, taking your meds on time, eating well, being active, and eventually attending cardiac rehabilitation. We recruited patients at the bedside from 2 metropolitan hospitals, but we're particularly interested in recruiting patients who were from the country. So we had an equal amount of country patients with city patients to compare. And we asked the patients to download 2 apps that were free online, or we gave them a phone with the 2 apps downloaded onto it. We asked them to charge their phones every night and carry the phone everywhere they went for the 30 days. We also asked them if they were still interested to continue to carry the phone for 90 days, because by that time they should have gone to rehab, and we wanted to see if we could see changes in practice. With the 2 apps, the GPS and the Google Fit activity monitor, we found that we were receiving a ping of data every 2 minutes from every patient, and there were 18 patients in our study. So in the end, we had 145,000 data points from the cohort of data. So we found that we needed to have a data manager for the analysis and to keep the quality and integrity and analysis. So that was a big learning experience, because we suddenly found ourselves in the big data world from this small observational trial. So that was a good learning experience for us, and important information for future trials, because we'll make sure we have a data manager budgeted for who can manage the data. Also the apps, although we didn't want to invent an app for this study and we just wanted to get free commercially available apps that we could access the data from, we found that they weren't that high quality. So maybe in the end we'll have to design our own apps. But we were also thinking that patients will most likely go home and download apps from the internet, and so we need to know what the good apps will be. So it was good to test these 2 as well. So probably the biggest learning outcome for us was data management, the big data that we had to analyse for this study. Overall memory of their discharge education was around 60%. 100% remembered their cardiac diagnosis. 40 to 60% of patients remembered they had high blood pressure and diabetes. 60% remembered they were told to do activity and look at their diet. 90% remembered they were restricted in driving for a period of time after that. So the recall of the education was limited. Activity, as far as step counts, daily step counts were concerned, was good to moderate in the first 30 days, 2,000 to 4,000 steps per day. Country patients were actually slightly better, statistically better at being more active, which was not what we expected. And unfortunately, activity decreased into the 90-day period. So there's some motivation needed there. And as far as the GPS tracking, we asked each patient to give us the address of their healthcare providers, their pharmacist, their GP, their cardiologist, where they have their bloods taken. And using the GPS tracker, if they were within 50 metres of those addresses, we counted that as an attendance. And attendance was quite variable. It was higher in country patients as far as compliance to attending those were, but it ranged from about 13% seeing their cardiologist to 62% seeing their pharmacist. So also more improvement was needed there. So we learnt a lot from what happens in the 30 days after discharge, and we actually learnt a lot about where we as researchers and clinicians can make improvements and support patients. We have clearly identified a gap in the quality and standardisation of discharge education for ACS patients. And so where we're going to work is using our avatars and digital health. We're going to prepare some standardised discharge education tools for nurses to give to patients at the bedside, and then give patients tools like the apps that we use to continue to monitor their adherence to those discharge education guidelines.